everyone, welcome back to the Orthopedic Tutor channel. So today we'll talk about the last part of the brachial plexus injury video series, which involves the management program. Now, if you have not read or studied the basic anatomy of the brachial plexus, I suggest you check out my first video regarding the brachial plexus anatomy first and all the relevant structures that are needed before you move on to watch this video. Now, let's move on to today's topic, which is the brachial plexus injury management. The discussion regarding the causes, signs, types, physical exams, and also additional examination is covered in the first part of this video. Now, moving on, when we talk about brachial plexus injury, there are certain things that usually come to one's mind, which is how to treat it, what to treat it with, and when do you treat it with. So generally, as with all other types of conditions, there are non-operative and also operative types of management. For the non-operative type of management, there are the ones that you do pre-operatively, and there are also the things that you do post-operatively. So I would like to go through the things that we do pre-operatively first. So the things that could be done for a pre-operative or the non-operative group patients are these 9 things. The first would be slings and splinting. The second would be passive range of motion, along with massage for edema control and scar management, followed by electrical stimulation, neuromuscular re-education, active assisted ROM, down to active ROM, strengthening and sensory re-education. Now, for the preoperative one, the slings and splint, you generally do it or put it on because we would like to prevent any shoulder subluxation because of the weakening of all the muscles that goes around our shoulder, and the splint is generally placed on over the wrist to prevent any contracture of the wrist, especially wrist flexion contracture. So you place the splint on our wrist in a position of around 10 to 20 degrees of extension. Now, for the passive range of motion, generally the patient should be educated to move around their joint in their full range of motion so that the patient can still have a good joint function following the return of the function of the nerve. The third would be edema and scar management. This could be done non-operatively by various cold compresses or also scar massage around the wound area or wounded area around the neck where the brachial plexus is situated at. So you would try to prevent any addition of the scar to the structures below it. Now, the next thing you could do is electrical stimulation. Now, electrical stimulation is generally done before any neurotization surgery, any tendon transfer surgery, or even free functioning muscle transfer surgery. Generally, what we do is we use direct current stimulation with devices such as these, and these are home use device. The patient could be educated to use this device on their own. Now, generally, when we talk about this electrical stimulation, we use the direct current stimulation, and one needs to know how to evaluate the effectiveness of our direct current stimulation. So you need to know about the 2 terms that are generally used, which are the Rio base and also the chronaxie. So Rio base is generally the smallest amplitude of current or electricity that you give for an infinite duration, which produce a minimal response on the muscle. So basically, it's just the amount of electricity, the smallest amount of electricity that is able to produce a muscle contraction or muscle response. So the next term would be the chronaxie. The chronaxie is the shortest stimulus time at twice the Rio base, which will produce a minimal perceptible response. So by knowing these terms, you could objectively know whether or not this patient has a denervated muscle, because if the patient has a denervated muscle, they will have a chronaxie that's longer than 20 to 30 milliseconds, and most often is close to 100 milliseconds. And in normally innervated nerve, it should usually be less than 1 millisecond. Now, the next thing you need to do is to know what to do in patients with post-operative period of time. So for the non-operative method that you could do or employ in a post-operative category of patient, the first thing would be to initiate immobilization so that you can protect the tissue healing of the various procedures that you have done, which could be a nerve procedure or muscle procedure. So generally you would like to place the patient in a shoulder immobilizer for around 3 weeks, or you could also place cast or splint for any distal surgeries. Now, passive range of motion is done in various sessions, which would be around 4 to 6 times a day with 10 to 20 repetitions or more, such as those depicted here. Now, you do it to prevent contractures, but you need to remember that you do the passive range of motion instead of passive stretching, because when you do a passive range of motion, you do a range of motion in an unrestricted manner, but you do not do any motion that exceeds or do any range that is bigger than your normal range of motion, because stretching will destroy the tissue that you have just repaired. Now, the third thing that you could do is the edema and scar management. So the edema, you could do decongestive massages, elevation or compression sleeves, while the scar could be managed by performing massage around the scar to keep the scar mobile. Now, for the electrical stimulation that has been mentioned before, there are several things that you need to remember. First would be the timing. You do not do it directly after the surgery, but you need to wait for at least around 3 to 6 weeks, because by that time the nerve healing would be progressively getting better, and therefore you will prevent any rupture of the repaired tissue. Now, for the type of the electrical stimulation, for cases of re-innervation procedure, so the muscle is generally unresponsive to currents produced by neuromuscular stimulators, so you need a galvanic type or a direct current type of stimulator. And by doing this, you need to evaluate the improvement of chronaxie, because by knowing the value of the chronaxie, we need to know that we are able to predict, because when it goes below 20 or shorter than 20 milliseconds, the chronaxie period, then generally voluntary contraction will begin spontaneously. So how to do electrical stimulation is that you need to use a home device, and you need to teach the patient to do it at least 2 to 6 stimulation sessions per day, and you need to stimulate at least 30 to 60 moderately strong contractions, or what we call as a moderately strong contractions are those contractions that are visible to the eye. Now, for cases of, for the next thing that you could do is called the neuromuscular or muscular education, and also the biofeedback. For nerve transfer patients, you need to re-educate them based on the nerves that are used, because you are transferring the nerve into a new place or a new home. You need to teach the muscle to have to take over the place of the muscles that are being replaced, or the nerve that are being replaced. So if you do transfer using intercostal nerve, you need to do breathing techniques such as deep breathing, pursed lip breathing, coughing, yawning, or Valsalva maneuver. Now, if you use a spinal accessory nerve, then you need to do exercises such as elevation of the scapula or shoulder shrug. And if you do the contralateral C7 transfer, then you do mirroring exercises. Now, the results of these things would be functional contractions after around a period of 2 to 3 years. One needs to be reminded that nerve transfer results are most frequently not readily visible immediately after surgery, and therefore patients must be extremely patient to keep on doing the exercise and wait for the results. Now, biofeedbacks. So for biofeedbacks, you need to use specialized machines here as depicted in this picture here. We could see that the patient is using a portable biofeedback units that the patient use at home, and if patient does not have this sort of machine, then you could use neuromuscular re-education or even neuromuscular electrical stimulation, so that the patient can get a visualization and sensation of the contraction. So once again, the patient is being asked here to contract, and while contracting here, the contractions are gauged by this unit here, so the patient can visually see how much power is generated, how much process is happening around the muscles that he is training using this unit here. Now, the next thing you could do is called the gravity eliminated exercise, where the patient is actively doing motions but with the gravity eliminated as seen in this picture. The next thing after mastering the gravity eliminated exercises would be the strengthening exercises, which starts from 0.1 to 0.35 kilograms of weight. Then the last thing to do is sensory pain management and sensory re-education. Now, patient must also be cautioned regarding the possibility of formation of pressure sores and injury to sharp objects, because the area that is being progressively monitored is experiencing loss of sensory function. So sometimes there could be wounds around those areas, and the patient needs to regularly check him or herself to prevent any infection. And then if some perception of the sensation is already present, then there will be a role for this type of rehabilitation, which is called the sensory re-education. Now, after you know all the sorts of non-operative treatment, we move on to the surgical type of treatment. Well, for the surgical type of treatment, there are things you need to know starting from the indication. So generally, you only do surgery in cases where there is definitely no hope for any further spontaneous recovery. You also generally do it for laceration injury in proximity to the plexus, because in this case, you definitely know that there is no hope for spontaneous recovery. Next, you also do surgical treatment for cases where there is definitely no clinical or electrophysiological recovery, and cases with electrophysiological recovery but no clinical recovery. Now, even though this seems like a good option, all of these indications, there are times when we cannot do a surgery, and there include the first and foremost would be the unrealistic goal, because some patients cannot accept their condition that the plexus injury, let's say, involve the whole plexus. The patient sometimes comes to us and wants to restore the function so that it could function at least 90 to more approaching 100% of the pre-injury level, and these are called unrealistic goals. So the next contraindication would also be unwillingness to go an extensive procedure and rehab protocol. So other contraindications specific for nerve transfer injury is the timing. If the injury has occurred around after 1 year of injury, then generally you do not do a nerve transfer procedure. Now, for the nerve transfer itself, before we talk about the options, we need to discuss about the timing first, because there are generally two types of timing for a patient with brachial plexus injury. Basic considerations include better functional outcomes will occur if there is spontaneous recovery, and surgery is needed when there is no spontaneous recovery. And the next thing is that better outcomes will happen if the surgery is performed earlier. Now, for the types of things that you could do include the types of timing. It includes the primary reconstruction or the secondary reconstruction. You call it a primary reconstruction if you do it in an immediate fashion or delayed fashion. So it is called an immediate surgery when you do it immediately within days. So what you can do here in sharp open injury and plexus deficit, you could do immediate exploration and repair of the plexus, and in cases with blunt laceration, you could do it better in a subacute phase, which is around 3 to 4 weeks, because it shows a better injury delineation. Now for the delayed type of primary reconstruction, you can do it within months, but generally you do not wait for more than 6 months because there will be diminished outcome for any reconstructive procedures. The options of doing the delayed type of primary reconstruction is in the cases of close traction of gunshot injury, because in this case, generally one would observe first for any spontaneous recovery of function. And you do it in cases of high suspicion of avulsion injury, where you operate at around 2 to 3 months. But if you do not suspect it to have any avulsion injury, you wait for longer, which is around 3 to 6 months. Now, after the primary reconstruction timing, next comes the secondary reconstruction. And secondary reconstruction are those procedures that are done in patients that are usually seen late or around more than 12 months following injury. Now what you do here is usually you do distal nerve transfer only in select cases with periods of less than 18 months or less than 1 year. Now the types of things that you could do after 1 year includes the tendon transfer, free functioning muscle transfer, or any bony or soft tissue procedure. Now that you know the good timing or how to determine the timing of the procedure, the next thing you need to know are the priorities, because patient often comes with different priorities. Some wanted to restore their elbow function, some wanted to restore their shoulder function, and some are more focus on their hand function. But generally, when patient comes with multiple deficits, the things you need to reconstruct has its order, and it goes from elbow flexion down to shoulder stability and external rotation, and down to the hand function. Although different references would explain it differently, because some authors would state that shoulder function or adduction function is important because it helps the brachial thoracic pinching function of the upper limb. But generally, most papers would state that the elbow flexion is one of the most important things to restore first instead of the shoulder function. Now, the techniques for the surgery options also differ depending on the type of the treatment, which is the primary type or the secondary type. If the treatment is being done in a primary fashion, then there are several types that can be done, which is these 5 types. The first would be neurolysis. What you do in neurolysis is that you release all the adhesion of the nerve, whether it's an internal neurolysis or the external neurolysis, and then what you can do next is to repair. Now the repair of the nerve itself could be done in a epidural fashion or fascicular fashion. And if you cannot repair, then you need to use a graft. Now the graft itself could come from a autograft, allograft, or even synthetic grafts, such as shown in this picture here, where the synthetic graft is covering an area where the nerve recovery is occurring. Now the source or the good source of autograft would generally come from the sural nerve, the medial brachial cutaneous, or the medial antebrachial cutaneous nerve, and also other sorts of nerve. Well, these nerves can be harvested from the brachial plexus itself. Now, the next thing to know is the nerve transfer procedure. Now, the question that may come to you is, why do you need to transfer a nerve? Well, the answer to that is that sometimes there are insufficient number of proximal axons that are available, such as in cases of root avulsion. Because in those cases, there is no longer any good proximal source of innervation, then you need to transfer the nerve from somewhere else. And judging from that, there are a lot of techniques that you could do to transfer a nerve, but the techniques of suturing it can generally be divided into 3 techniques, which are known as the end-to-end technique, end-to-side technique, or the reverse end-to-side technique. Well, we can see here that the D is the donor and R is the recipient. If we stitch the proximal end of the donor down to the distal end of the recipient side, we call this an end-to-end nerve transfer. But if we stitch this, or we repair this nerve by transferring, we stitch this donor nerve here to the side of the recipient nerve, then we call it a reverse end towards the side. So end to side reverse nerve transfer. And if you stitch, instead of moving the donor side, you move the recipient side towards the healthy area, then we call it an end to side nerve transfer. Remember that the reverse surgery is done when the donor is cut off and moved to the recipient side, and we call it a usual or common end to side if the recipient is being moved while the donor part is intact. Now, there are several nerve transfer techniques that is very popular, and those are the ones that restore the suprascapular nerve by using a spinal accessory nerve, also known as the these are known as the spinal accessory nerve transfer. The second transfer would be the transfer of spinal accessory to the musculocutaneous to restore the musculocutaneous function, and there could also be a transfer of median or ulnar fascicle transfer towards the brachialis or biceps to restore its function, and this would be called the Oberlin transfer. And next would be the intercostal nerve transfer to the musculocutaneous, and also there could be a contralateral C7 transfer to median nerve with vascularized ulnar nerve. Now, these are only the commonly used nerve transfer, but there are also other sorts of transfers. But for me, I would just like to remember these because these are the more frequently used type of transfer. Now, other sorts of primary procedure that you could do is the free functioning muscle transfer, and it could help even to restore the grasp function. Now, for the secondary type of surgery, there could be surgery towards the shoulder region or the elbow region. For the shoulder procedures, it includes tendon transfers and also shoulder arthrodesis. For the shoulder arthrodesis, you need to evaluate the trapezius and also the serratus anterior function first, because if these muscles are functioning well, then you can do a shoulder arthrodesis in a position of 30-degree abduction, flexion, internal rotation. But if you have an abnormal trapezius and serratus anterior, then no arthrodesis is recommended, except in cases of severe symptomatic inferior subluxation. So you need to do desis in this position of 1, 2, 3. 1 or 10 degree of flexion, 2 is the 20 degree of abduction, and also 30, which is the 30 degree of internal rotation. Now, the next procedure that you could do around the shoulder is called the tendon transfer procedures. Now, the tendon transfer procedures include transferring these various tendons, which is the upper trapezius transfer, pectoralis major transfer, lower trapezius transfer, and also the latissimus dorsi transfer. For the upper trapezius transfer, you could move the upper and middle part of the trapezius along with the clavicle bone segment, and you fixate it to the proximal humerus, and these are known as the Saha procedure. As you could see here in this picture, there's a part of this trapezius that is cut out along with some part of the clavicle, and then you reattach this bone segment here down to the proximal humerus region. So the function of the trapezius muscle is being shifted. It goes all the way to the shoulder and helps its abduction. So the next thing you could do is the elbow type of procedures. Those previously mentioned are those procedures done for the shoulder. Now for the elbow type of procedure, there are several famous procedures such as the Steinler procedure, where you move the common flexor origin from the medial condyle over to the anterior distal humerus region. Now this procedure is rather straightforward and not that difficult to perform, because you only need to remove the attachment along with its bony fragment and you refixate it over at the anterior distal humerus region. Now the second procedure that you could do is a triceps to biceps transfer to help restore the elbow flexion, and the latissimus dorsi transfer, which could be unipolar when you only move the origo of the latissimus dorsi muscle, or the bipolar type of procedure when you move both the origin and insertion. The origin is then transferred to the coracoid process and the insertion is transferred to the biceps tendon. And then the last procedure that you could do is the pectoralis major transfer. Now to end this video here, I would like to give you a summary of procedures that is considered a must know. So while you're experiencing an orthopedic board exam, especially in Indonesia, there are several procedures that you need to know, and it includes these 5 procedures. Now, the first would be the Jones procedure. You need to do the Jones procedure to restore a wrist extension motion. So the classic Jones procedure, it includes transferring the pronator teres to the ECRB. You need to transfer the FCR to the EDC and also the PL to the EPL to help restore the wrist extension, finger extension, and also the thumb extension. Now the second thing that you could do is to transfer the spinal accessory nerve up to the suprascapular nerve, because by doing so you can help restore the function of the supraspinatus and infraspinatus. And next would be the Oberlin transfer. The Oberlin transfer is done by moving a single transfer of the ulna or the FCU branch of the ulnar nerve up to the biceps. So you try to restore the elbow flexion and also supination by using one part of the ulnar nerve, the one that goes to the FCU. Now the thing is, you could also do a double transfer. So you take a part of the ulnar nerve that goes to the FCU and also a part of the median nerve that goes to the FPL. You transfer both of it up to the musculocutaneous nerve. So that is described as described by the McKinnon. The next procedure is the Steinler procedure, which has been mentioned earlier, where you try to move part of the origin of the flexor muscles down to the distal anterior humerus. And then there is also the Saha procedure, where you want to move part of the trapezius along with the bony clavicle down to the proximal humerus region to help restore the shoulder abduction. Now, I think that would be all for today's video regarding the complete treatment of brachial plexus injury, including its timing of surgery, its options in non-operative and operative treatment plan. Be sure to check out my previous video regarding brachial plexus injury to help you understand more about how to diagnose and how to determine the location of the lesion, so that you can choose the appropriate type of surgery that you want to do to restore the functions that are lost. Thank you for watching once again, and don't forget to subscribe to the Orthopedic Tutor channel.